Our next presenter comes from Southwest Healthcare and Deakin University, Dr. Margie Morris, and her topic is engaging hard-to-reach rural populations in bowel cancer screening, alignment with systems thinking. So please join me in welcoming her.
Thanks very much. I'd like to come up here. We're actually a team today, so we're going to try and coordinate because we very much worked as a team. So I just wanted to also thank that we've got a much bigger team on our hands through Southwest Healthcare and a number of other organisations, including Vince Versace, and also like to acknowledge that this is a 2-year pilot project funded by the Department of Health and Human Services as well. I'd also like to thank Jan Vanderstoel last night for recognising our talk, and we had an alternative title called More Poo in the Post, so I'm wondering what she would have made of that last night. Seriously though, bowel cancer is an incredibly important chronic disease issue. In fact, Australia has the second highest incidence in the world, second to New Zealand. So a few analogies across the Tasman. But so our key drivers were the fact of the high incidence, but also we have one of the best evidence-based screening tools available to us in the world as well. So it would seem quite simple. We need to use the National Bowel Cancer Screening Program, which started in 2006. And yeah, it would seem quite simple that that's being implemented, but no. It's a very complex problem. We basically have people that are posted their kit in the post and they receive it. They have very little connection with their GPs. There was not very strong integration with general practice in terms of delivering this nationally. And we also have very low take-up of this. It's currently only around 37% nationally. In our region, we are quite similar to the national average, and I guess this project, the driver was around trying to increase that rate, find some local strategies to help improve that. So our main focus is on under-screen audiences, which are your typical ones we've seen in the last few talks around being men, but actually only a few percent less than females, around our low socioeconomic and also around our Aboriginal and Torres Strait Islanders. So the system here is defined to include a range of people involved at every point along the pathway screening. So we had a boundary, which is the local government areas of Corangamite, Moyne and Warrnambool. So we took, interesting Sonia's talk, we took a comprehensive and we think a systems approach, if that's possible. Basically looked right across the whole system from people getting to screen, getting them re-screening and getting them followed up if they have a positive test. So we worked right across community awareness, around health professional awareness as well. There wasn't a conversation happening at all across the region. And we also looked at systems in place within health professionals, particularly GP clinics. And we also followed that up with some extra funding we got to work on redesign in our Southwest Healthcare colonoscopy services. So this is our catchment. We've got Moyne, as I said, Corangamite and Warrnambool, and this is a plot I put together just to show you the main areas of activity where we undertook interventions right across that space, but also to show you that we worked outside those boundaries, and we'll talk a little bit more about that.
Okay, I'm Elvira and I worked with Margie on this project. And so there we go. Just pictured above was we had the particular challenge of trying to get a whole lot of people interested and started on the journey of even thinking about doing their bowel cancer screening. And that's just a visual of some of the different groups of people that we were trying to engage with through our project. And why we wanted to bring this presentation here today, we were really interested, we both have a background in systems thinking but in different disciplines, so we had kind of come into the project interested in some of those ideas but kind of, learners. We've got our L plates on, having a go in a health context. So we were lucky enough to have a very strong project team which did include people with a very strong commitment to health promotion, but also, organisationally, Southwest Healthcare is very embracing of innovation. So we had that support to try a few things. Western Alliance put up a small scholarship to try and help practitioners to think about how their practice might engage with research. So that's kind of where we we kind of come in. And also, we were basing our project on significant policies. So what Sonia was talking about before, practitioners, research, policy. So, and that policy is coming up to speed with systems thinking. So, we were really trying to think about how do we actually make an impact here. So what we're trying to do in this process is kind of go, where did our project align with systems thinking? And we're hoping that for this audience in particular, it will just help increase that dialogue. So there's very comprehensive work that's done on particular issues. We're seeing how did this relate to a bowel cancer prevention project. And so with the support of Western Alliance and with Vin's help, we had a go at creating this causal loop diagram. And so what this is, for people who weren't there yesterday, were all the potential different variables that might be impacting on low screening rates. And then the arrows are how these kind of interact with each other. So, we kind of were intuitively thinking about those kind of interactions, but this really kind of helped us map out the completeness of that. So it's a work in progress. We've had a go. We've had another look at it, and we're just going to draw out 3 examples from that to kind of show how that systems thinking, enabled some things and, where there's still work that could still be done.
So I guess it's actually going a bit backwards, but one of the key things we've ended up doing is to bring together a whole lot of data, and I'm a bit like some others in the room, I love data. It's very powerful for giving messages and moving things forward. And one of the first things we realised was that there was another significant player around screening in the region, and that's Rotary. So Rotary have been providing screening kits for at least a decade, and there's great community support around regular screening in that program. So that was one of the first things, was to build some alliances and dialogue with those sorts of other organisations. So what we've managed to do, and we're just working this up with the help of Dr. Anton Forsyth from Flinders University, is to develop a peer-reviewed paper on looking at actual overall participation. It's not just about the National Bowel Cancer Screening Program. We've got a moving, changing field in that area, and with the program rolling out very slowly for full implementation for every 2 years from 2020. So just in the meantime, we want to try and understand these other sources of true screening. And so in that process we went through to look at some of these factors, it was very clear to us around that all these sorts of things affect data quality, which is right in the middle there. So this is just an early diagram that I've put together for the number of screening kits completed. You've got the green, which is Rotary kits, and this is from 2012 to 2015, and we're getting current 2016 data as well. And the national program is gradually going up because of that slow rollout I was telling you about. So we're getting more people invited, so that's why that's going up. We're also brought in some doctor-related data, because doctors also offer fecal cult blood testing in their clinics. That's for those who are eligible to screen and also non-eligible. So we're going to look at teasing out some of that data by getting some local GP data as well. But I guess the take-home message of this one was the fact that Rotary, yes, it is a significant player, and we need to look at that future of how we work with using a more free kit, and their role in the future may be important around education advocacy for screening. So one of the key areas I've been working is around all health professionals, their support systems. They have none. They haven't had any in the past, and so it was developing that from scratch around education, around the rollout of the National Bowel Cancer Screening Program, around resources that were missing. So, for example, knowing which patients were eligible, knowing what their screening pattern currently is and how they might need to fill that gap, and the time that the national program was rolling out fully. But the main thing in terms of systems was looking right across those issues affecting within GP clinics and their role, that there's high connectivity between all those sorts of factors involved. So some of the resources we've been working on is a complete package for GP clinics around basically how they talk to their patients, have those conversations, resources to support those conversations. Also, which includes on the left there, we've developed a conversation guide for nurses and health workers. We've also got one specific to our local Gunditjmara and Kero health services as well. And the great news is that that's going national, which we're very excited about. Also, I've done some mapping around pathways within GP clinics for not just how the data's coming into clinics, but also how those patients are flowing through so that they're picked up in the system and get recalled as well. Also, we've developed a new referral form to South West Healthcare. So that's about standardising categorisation of those patients so the right patients are getting in at the right time.
Okay, and just a really different part of that whole systems map is the giant knitted bowel. So this is a great example of responding to feedback. We had to deliver community education to under-screened groups. So in our area, farmers, local Indigenous communities, people of a lower socio-economic status, so I guess there's your traditional, give them the information and they will agree with you and do it. And then we thought we've actually got to get innovative here, and the leverage or the tipping point for this was meeting up high with Gunditjmara, one of the local Aboriginal health services, and the lady kind of going, yeah, this is important to talk about, but you can't talk about it. So, come along, but don't talk. And she said, oh, and would you mind if these ladies knit? And, I'm a knitter, so I thought, maybe we could do a project together. So, it just highlights how important it is to get any of that feedback and find those ways in with people. So we were thinking about conversations that were culturally inclusive. So, getting together with a range of people and getting people on board with a whole cause. Right through to from the way we exhibit it in shopping centres rather than art galleries. So we were really thinking about where's the feedback of where these people are and how do we go out to be with them. One more minute. So a key learning about it was also these people are all on social media. So while we couldn't talk to them directly, we could get stories and voices and, key messages always up there, simple messages that we wanted people to hear. And our bowel cancer clip is up on the South West Healthcare website. And we had 5,000 views for, this fantastic collaborative clip we did about bowel cancer and raising awareness with voices from our target groups, really kind of pushing and promoting. So just quickly, systems mapping. So what that did for us was to really, see where the interconnections were and to really be responsive to that feedback. So having our baseline, but really responding to emergent opportunities. So we're just to finish, we were keen to put this project up and we would love feedback. We're really thinking about, how best to frame this and, how other people might learn from this. So see us at lunchtime.